محمد وعلى آله وصحبه أفضل الصلاة والتسليم. السلام عليكم ورحمة الله وبركاته. Good morning everyone, and hope all of you doing well and excited about this conference. Before welcoming you to the conference, let me first welcome you to your second country, Saudi Arabia, and your second home, Al-Ahsa. And I hope to enjoy here during the upcoming few days and know that our hearts are open even before our doors. To start off, let me introduce myself. I am Dr. Hussein Adel Ghadir, pediatric resident at Maternity and Children Hospital, Al-Ahsa. I'm glad to welcome everyone here for this much awaited, excited conference on its first day out of 3 days, and I hope to enjoy during these days. وخير بداية نفتتح بها هي آيات عطرة من الذكر الحكيم.
الرحيم. سبحان الذي أسرى بعبده ليلا من المسجد الحرام إلى المسجد الأقصى الذي باركنا حوله لنريه من آياتنا إنه هو السميع البصير. وآتينا موسى الكتاب وجعلناه هدى لبني إسرائيل ألا تتخذوا من دوني وكيلا ذرية من حملنا مع نوح إنه كان عبدا شكورا. وقضينا إلى بني إسرائيل في الكتاب لتفسدن في الأرض مرتين ولتعلن علوا كبيرا. فإذا جاء وعد أولاهما بعثنا عليكم عبادا لنا أولي بأس شديد فجاسوا خلال الديار وكان وعدا مفعولا. ثم رددنا لكم الكرة عليهم وأمددناكم بأموال وبنين وجعلناكم.
صدق الله العلي العظيم. Will the audience please raise if possible and face the flag for playing of the national anthem.
سارعي للمجد والعلياء مجدي لخالق السماء.
وارفع الخفاق أخضر يحمل النور المسطر رددي الله أكبر يا موطني.
عشت فخر المسلمين عاش الملك للعلم والوطن.
سارعي للمجد والعلياء مجدي لخالق السماء.
وارفع الخفاق أخضر يحمل النور المسطر رددي الله أكبر يا موطني.
عشت فخر المسلمين عاش الملك للعلم والوطن.
Now please join me in welcoming Dr. Maryam Al-Amri, Chairwoman of the Organizing Committee, Head of Pediatric Department at Maternity and Children Hospital, Consultant Pediatric Nephrology and Renal Transplantation for the welcoming speech.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Ladies and gentlemen, good morning everyone. It's my pleasure and honor to welcome you all today and to announce the official start of Al-Ahsa Advanced Pediatric and Neonatology Critical Care Conference. This event that took from us as an organizing team a lot of effort and time. This is really special event for us because of you first, our guest, the scientific committee and the speakers, very distinguished name, experts and pioneers. We are really fortunate to have you with us today here in Al-Ahsa. The idea of our conference started 1 year ago after our last year pediatric conference. We want to join the subspecialties of pediatric and the other subspecialties related also to the pediatric under the umbrella of critical care. We touch also the organ donation, the ethics. We have a special session for this. And also we have workshop in the third day, very interesting subject. I wish inshallah you will enjoy our scientific program. Before we proceed, I'd like to express my deep gratitude to my team, the organizers, by names, and to the scientific committee for their effort. First, Dr. Fatma Al-Khalifa, my deputy, the deputy of pediatric department, my like-minded, my close friend, and my confidant. Thank you, Dr. Fatma. Second is Dr. Ali Al-Fayez, is the head of pediatric ICU, and he is the mastermind behind this idea of the conference and the driving force for this event. Dr. Faisal Al-Dandan, the head of neonatology department, he is the other driving force for this event too. Also for our ever active secretary, Mr. Jawad Al-Mutawwa. Thank you for you all. Special thanks also to the hospital, our leaders, the director of the hospital, the medical director, and the department pediatrics, all the members one by one. Thank you all for your support. Of course, a thanks to the hospital director, the medical director, and to our big family, Al-Ahsa Health Clusters, for their unwavering support. It will be represented today by Dr. Turki Al-Isawi. Thank you, Dr. Turki, for your coming. At the end, I would like to thank the sponsoring companies. Huge thanks for your support. Sorry for the delay, and now we can say that our conference is officially starting. Thank you so much.
Thank you, Dr. Mariam, for your welcoming speech. And now please join me in giving a warm welcome to Dr. Turki Al-Isawi, Executive Vice President of Therapeutic Services in Al-Ahsa Health Cluster.
Assalamu alaikum wa rahmatullah. Dr. Mariam, Scientific Committee, Organizing Committee, guests and speakers. First of all, I apologize. I'm the reason for the delay of the day. Appreciate you attending and contributing and in such a huge scientific program that we are 100% sure that going to enrich the healthcare in Al-Ahsa region and the whole region of the Kingdom of Saudi Arabia. I won't take much time, but this is happening definitely with a great support from the sponsoring companies and the great contribution from our partners in business and in healthcare. Thank you very much for the sponsoring company. Thank you very much for the organizing committee. Thank you very much for Dr. Mariam and the team and the directors and the executives of MCH and King Faisal Hospital as well. Guests and speakers, I won't take much of your time. Please enjoy the event, and we appreciate all the contribution in the scientific optimization and growth in Al-Ahsa region. Thank you very much.
Thank you, Dr. Turkey. And now be ready and buckle up your seat belt and stay focused. And now you will join us during the first session of the day that will consisting of 3 interesting topics in pediatric intensive care. Now please join me giving a warm welcome to the moderator of the session, Dr. طارق العايد. Dr. طارق العايد is a pediatric intensivist at King Faisal Specialist Hospital, Research Center in الرياض, Section Head Pediatric Critical Care, Department of Critical Care Medicine.
Assalamu alaikum, صباحكم الله بالخير. Good morning, everyone. First, I'd like to thank the organizing committee for inviting us for this an excellent, huge conferences, and also for their hospitality. Al-Ahsa is a well-known region for us in regard to, an excellent achievement in educations. As part of multiple or many conferences that we have been done, Al-Ahsa region was really one of the best area in regard to a number of attendees, and also in addition to the qualities of people attending. Without taking long time, we are going to start our first sessions of pediatric critical care. To keep you hot, I think is always good to start with the critical care. It's going to be of three different talks, including a panel discussion. Our first speaker is د.ايمن العياضي. He's Vice Dean of Quality and Development at King Saud University, and he's a professor of pediatric and pediatric critical care. He's a well-known senior speaker. He's going to talk about medical error in pediatric critical care and family disclosures, and very important topics we always encounter either in critical care or non-critical care area, how to disclose this medical error. So I'd like to welcome Prof. Ayman to give us some talks about this an important topic. Thank you.
السلام عليكم ورحمة الله وبركاته. سعد الله صباحكم جميعا بكل خير. Good morning, everybody. What a pleasure to be among my colleagues and friends in Al-Ahsa Hospital and Al-Ahsa area, and what a pleasure also to form new friends in this wonderful area. And many thanks for the organizing committee for the invitations and for the nice hospitality for the conference. Okay, so I was thinking a lot when we present something related to medical errors. It is an area of inconvenience, not only to be in, but also to talk about, because it is emotionally loaded and it has lots of perspectives that everybody would like to share probably and have questions about. However, let's start with triggering scenarios. So how many of you had similar scenario in your practice, in the ICU specifically? A child who is intubated suddenly extubates himself while moving because of under sedations, and probably the nurse was not around getting some medications. A child who developed central line associated bloodstream infections after prolonged hospitalizations. How many of you, just by hands, have seen similar examples? Okay, so it's not a few, it's a lot. It's a very common, unfortunately, to see these type of events. So the question is this a medical error? So how many of you think that this is a medical error? Okay, so we have one, probably two, three, so only a few. So let's go and see different case scenarios. So a nurse preparing medications for the critically ill patients while double checking with a colleague realized that it's a similar in name to another drug in the unit. So a medical error was about to happen but prevented. Using a barcode scanning technology, verifying the dose against the patient's health records, the nurse was about to have an incorrect dosage based on weight, and this is prevented an overdosage practice. A long-term patient in the ICU was at risk and decided to be at risk or assessed to have high risk of pressure sore. So there was a protocol implemented for a regular patient care to prevent pressure sores, and patients successfully left the ICU without a pressure sore. So how many of these you think, without implementing double checking, for example, or verifying technology, or proactive measures, would have resulted in a complications or medical error, probably? With the same analogy, let's go back to our case scenario. So a child who's intubated suddenly extubates himself while moving. So the implementations of a protocols for securing tubes, emphasizing the monitoring and prevention strategy during high acuity setting could have prevented such an incident. So do we agree this is preventable? If yes, just hands up, please. Okay, so just focus on the word preventable. So the other child with central line related infections, when we performed a root cause analysis and investigations, we found probably that the hand hygiene compliance was suboptimal. So looking at this practice and reviewing this practice, emphasizing the importance of all elements of bloodstream infections preventions, probably will decrease this practice a lot. We will not see this. So this is again preventable. So once you hear it is preventable, then probably it can be categorized under the medical error. There is so many misconception about what could be a medical error, what could be a complications or adverse events from the disease, from the care, or from the process overall. So adverse event is to unfavorable outcome from the care overall. So it is a complication because of disease, complication because of the procedure, because of the care overall. But it is somewhat expected. While medical error, it is something preventable. And this is resulted from a deficiency in the process of care. So anything that is violation from the standards and it is preventable, probably it can be categorized under medical error. While sentinel event, it's a major and enduring loss of function of limb or death. And why it is specific? Because in the regulations, it has specific pathway. Near miss, it is hazardous situations that did not result in a loss, but could have. If it was not caught, it could have resulted in a bad or unfavorable outcome. Again, similar analogy will be applied to medications-related errors. So in adverse drug reactions, it is a harmful response during a normal practice. So it could be expected and cannot be prevented. While the adverse drug events, it is a bigger umbrella. So whether this is because of something expected like adverse drug reactions, or because of medication errors, or because of overdosing. So this is probably a bigger umbrella than the medication reactions. And I think this is very important to clarify terminology when we're documenting and recognizing different pathways for a different event. So medical error is the failure of a planned action to be completed, or it is a wrong plan that was achieved. So it's either an action problem or a decision problem, and both could result in a bad or unfavorable outcome for the patients. So in pediatric intensive care, it is a vulnerable area dealing with high acuity, vulnerable patients. So any unfavorable outcome could result in a really detrimental pathway for the patients. So it's very important to understand the nature and implications of these errors to prevent them. So what are the consequences of a medical error? There's a medical legal consequences, so a legal liability and malpractice claims, and also disclosure laws or violation of disclosure, and also there is an ethical consequences, which is violations of the medical ethics principles. So beneficence, non-maleficence, truth-telling, justice. Importance of truth-telling is crucial in understanding the pathway for medical error. Medical error can happen in different contexts. Some studies reveal that the majority of medical error is diagnostic errors. Around 70% of the medical errors are diagnostic errors or wrong diagnosis. And also it could be medication error. Again, it's a very common. The medication error is one of the commonest, actually. And surgical error or the procedure-related errors, and communication failures. Again, communication is part of the process of care, and any problems with the communications can be classified by itself as a medical error, or can lead to medical error. So here we have human factor analysis. So either it is unintentional error, so it is action problems. So the nurse, for example, would like to press button A, but wrongly she pressed button B, for example. Or it could be a thinking problem. It's a wrong decision. So, but both are unintentional. But let's talk about the other way. I will not say it is intentional to do the error, but it is intentional not to comply with the protocols, intentional not to comply with the guidelines, and not to do the right care for the patients. There's another error. It's not related to the human, and it could be latent error, and it's underlying the flaws in the system overall. So it is systematic in nature. So if you change people, the pattern remains the same. And it is dormant in nature. So if not looked at it, if the healthcare system doesn't look at it carefully, it can pass day after day until the event happens. So it's going to be too late to have it. So this is very important to have this practice analyzed in different ways. Example, you have a problem in the ventilator, for example, and then it passed first, second patients, no problems. But when a high acuity patient came, the malfunctioning equipment start to not to perform appropriately. And there was an error in the cyclic or regular maintenance for the machines. I apologize, this is way slow. Okay, so safety. So this is a nice mnemonic to remember that we have to sense an error before it happens. And if you sense the potential error, then act to prevent it as soon as possible. Act to prevent it as soon as possible. And one of the important tools to do is to follow safety guidelines overall. And this safety guidelines could be protocols or national, international guidelines, or a specific steps or pathway designed by the hospital. Evaluate the outcome. Make sure that always think about the outcome. Is this an anticipated outcome for the patients, or this is something that we could have probably deviated to a better outcome while following a pathway or guidelines if we have done something different. Okay, this is the landmarks for the Saudi Arabia key regulations in preventing medical error. Number one is emphasizing the importance of patient safety. And also in the Sipahi, there was a requirement that medical errors has to be reported. And if it's a sentinel event, it has to be reported within 24 hours in a specific format, a specific pathway, and escalated as soon as possible. And again, another important landmark in the healthcare in Saudi Arabia is the introduction of mandatory malpractice insurance. And this has been there for several years nowadays. Initially, it was for the doctors, and then it was widened the scope for most of the healthcare practitioners. So knowing all of this regulations, so this is a study to evaluate the gap between the policies and practice in medical errors. And this was a cross-sectional study of 206 physicians. There was significantly low awareness rate in hospital policies and programs regarding disclosure practice in the medical error. Higher level was associated with a better awareness, so consultants almost was 50% more likely than others to be aware, and also some gender difference were found. So the recommendation was that we need to have an advanced effort of hospital leaders need to be made to communicate, train, and educate healthcare providers about the medical error policies and to promote disclosure practice. Next slide. Okay. This is another study reviewing the minutes and the documents of the medical legal committee and the Ministry of Health. And this was almost 2007 to 2013. And they found that there is a significantly increasing trend in medical errors reporting. Conversely, the number of verdicts reaching to resolve was decreasing. So the number of claims increasing, but the number reached to full resolutions almost decreasing. The most common errors was surgical specialties, almost 56%, and non-surgical specialties is 44%, which is expected. Okay, this is another important study, I think, that also analyzed the 3,600 almost lawsuits from 2016 and 2018, and reflecting a 26 increase over this period. So there's again another study stating that there's an increase in the medical legal claims. Obstetrics and gynecology counted for the highest percentage claim at 25%, followed by, surprisingly, by dentists, 13%. The private healthcare sector experienced more than the governmental sector. So there was a recommendation from this study that we needed to develop a detailed reporting system for malpractice lawsuits. This is another study, also that cross-sectional study for more than 100 physicians, and 41% felt it was not their responsibility to report an error if they are not the most responsible physicians, MRP. So, and 43% agreed that they would hide their own error to avoid punishment. So this is very important. This is very important. So this was probably more than 10 years ago. So hopefully, and I'm sure mostly that this practice has been changing since then. Errors likely to disclose if they have severe damage. So majority believe that in the ethical obligations to report the error. This is again another survey of more than 460 clinical healthcare provider, and the most common barriers preventing the staff from reporting the medical error was fear of being blamed. So a culture here factor is very important. Fear of being punished. Again, we have to define when and where the just culture will be different. Difficulty in filling the forms. Lack of knowledge of what should be reported and the lack of knowing the procedure to do it.
5 minutes to finish, please.
So, and the most common strategies that the respondent felt that is important is to have a clear guidelines and procedure for reporting errors. The forms and documents need to be explained well and clarified, and staff should be trained always to do so. So the family disclosure is an important aspect of the equation. It is very important, however challenging. Many of us probably would be inconvenient in disclosing a medical error. Why it is challenging? Because it is emotionally impacted and loaded. The communications skills needed to be upgraded when we talk about medical errors. So there is no place for miscommunications. Sometimes there is uncertainty around the error, specifically immediately after the error happening, before the full investigation happened. The institutional culture is also affecting the openness and the transparency in the disclosure. The medical legal concerns also is another important aspect that if I tell the family gonna complain. The parental expectations complicating conversation. So if you have a precious baby for a family, it's different than a family who have multiple or other kids, or the personality in the family or the dynamic in the family can affect the disclosure. Very important in doing the documentations of the family disclosure. So very important to have a clear documentations in a systematic way. What are the common pitfalls of not documenting or any documentations? Usually lack of details. So we give overall idea without clear details of what has been disclosed. Using jargons in the technical language. Inadequate identifications of people. So we have to make sure that only people concerned with the child is present in the room. And try not to use subjective and stick to more objective informations. Do not neglect a follow-up. This is very highly appreciated by the parents. And also in the documentations when we look at it backward. Inconsistent documentation practice is another important. So make sure that we have a full systematic way of documentations. So not the resident, the specialist, the consultant, the other consultants, all they need to report with a consistent practice. Okay, so we are talking about medical errors, but I think it is very important to talk about the patient safety and quality of healthcare. This is extremely important as to increase the awareness. Because if we talk about medical errors, it means don't do and don't do. But let's reframe it, and reframe our mindset to have, let's do higher standard of care rather than just avoiding the errors. We know that the quality pillars in healthcare is we have to avoid harm to patients, provide an effective care for the patient with evidence-based, patient-centered, timely, care, efficient, avoid waste and healthcare delivery, and equitable, that everybody should be treated the same.
Time is up.
However, this is not a piece of cake. There's always challenging in doing that. One important tool that we have to optimize always is when we have a medical error is to use a root cause analysis. Root cause analysis is a systematic. It has to be done within a team, so you can't do it in your office. And you have to have cross-functional collaboration between different team members. And you have to document the change in the process. There's another more proactive way of doing that, which is the prospective.
Time is up, please.
Take home message. So we talk about the just culture and how important it is to develop. So in a take-home message, that maintaining high standards of healthcare quality and patient safety is crucial in healthcare and medical error preventions. So let's focus on the higher standard than thinking about the medical error. Understanding the difference between medical error and adverse event is very important, and we should train ourselves and our colleagues to do that. Effective disclosure and documentations are vital. Fostering a cultural shift toward a just culture is very important, and the need to effective approach in PICU prevention and the ICU to prevent the medical error is also important. So retro, like mortality, M&M meetings, root cause analysis, and pro-analysis, preventing the analyzing and preventing error before happening, And it is essential to prioritize ongoing training for the PICU team according to the needs overall. Thank you very much.
Thank you very much, Ayman, for very nice thorough view of this very important topics. Our next speaker is going to be Dr. Khalid العروان. He's a pediatric cardiac intensivist at King Faisal Specialist Hospitals, and he's going to talk about utilization of ventricular devices in pediatric cardiac patient. As you are aware that we are utilizing more of devices, so probably those patients already have been devices. You might see them in the emergency rooms, or coming for other reason. So you need to be probably familiar with these devices. So I would like to introduce Dr. Khalid العروان to come and talk to us about those devices. Dr. العروان.
Assalamu alaikum. Yeah. My talk today is ventricular device in Saudi Arabia. This is the cardiac ICU subject, so I take you from BICU to cardiac ICU. Most common cause of heart failure in children, usually the dilated cardiomyopathy, otherwise other causes like rheumatic heart disease and multiple other complex congenital heart disease. The incidence is being reported from 1 to 2 cases per million in population of different countries. In the USA, is 14,000 pediatric heart failure hospitalized, and the mortality is 7.4% rate. What is VAD? VAD is the mechanical circulatory device that used to replace the pumping action of the failing heart. And the goal of VAD is to increase cardiac output, improve the end organ function, and improve quality of life, and improve mortality and morbidity. It is a mechanical pump which is surgically attached to direct or indirect to the ventricles, either right or left heart. And it will support the ventricle by reduce the wall tension or myocardial oxygen demand, and increase oxygen supply, either systemic or coronary, and reduce inotrope dependency and allow heart to rest and recover for transplant. The waiting list, there is a study which recently have demonstrated 50% reduction in pediatric patients who receive VAD support. This is a slide from International Society of Heart and Lung Transplant, and the color is the green, which the number of VAD is increasing with the years. This is another study from the same society which demonstrates the heart transplant per year and per location. The green color is from North America, and the yellow is from Europe. What type of devices it have been? It is, I think, classification of VAD based on either temporary or short time, or permanent, and other for impaired ventricular function like LVAD, RVAD, and BIVAD. Other basis pumping, it is versatile or non-versatile. There is another one which is extracorporeal, which is the ECMO, and paracorporeal, which is versatile in the Berlin heart. Intracorporeal, which is continuous with the HeartMate 3, and total artificial heart, which is syncardia.
What's the difference between ECMO and VAD? ECMO is providing both blood flow and oxygenation, which is cardiac and pulmonary support. Whereas the VAD is only cardiac support, and you need good, normal function of the lung to have to put a patient in the VAD. It is short term in the ECMO, but in the VAD it can be long term until transplant, and relatively cheap in the ECMO comparison to the VAD. The indication of pediatric VAD is chronic decompensation of heart failure secondary to any cause, and it is bridge to transplant or bridge to destination therapy, and bridge to recovery, and either to bridge to destination. The progression of VAD, it is there's first generation, which is VAD and Berlin heart and total artificial heart, which is syncardia. There is second generation, which is HeartMate 2, and third generation is HeartMate 3. What's the difference between VAD and artificial heart? Artificial heart is the removal of the heart. They cut both ventricle and they fix the devices directly to the RVOT and RVT and LVOT. It is two types, 50 cc and 70 cc, and this depends on the age of the patient and the weight. So the second device is Berlin heart. Berlin heart is first generation, and it is a paracorporeal explorer ventricular assist device. It is varies from side from 2.5 kg till adult, and it is work with the air. So there is triple layer in the membrane surface, separate the blood from the air, and it is pumping and it is versatile. There is 6 available chamber. From 10 to 15, 25, 30, and 56 mils of Berlin heart. And this is the range to be started from children from 2.5 kg till adult. How to select the Berlin heart size? It depends on the weight of the patient and the cardiac output. They will calculate the cardiac output and the weight of the patient also. This is the machine of the Berlin heart, and see how it is in and out, and the system is bumping the left side and the right side, and there is a machine. And you found the bit side of the patient will have 2 sides. The green is the blue, it is the right side. We found the flow and the heart rate, and the red one is the left side. Third one is the HeartMate 3, which is the LVAD surgically connected to the patient's circulatory system by cannula in the apex of the heart and the other cannula in the aorta. And it is a centrifugal pump. You will find the outflow connected to the apex and the inflow to the aorta, and the driving line is and you see this can be carried in the shoulder with the battery, and he can be mobilized and can be outside the hospital. But the Berlin heart should be hospitalized in the hospital. This is the parts of the HeartMate 3, and the battery and the controller. And you found there is mobile also battery. They can hook it and he can go outside from home with it. This is the screen of the HeartMate 3. You found the speed and the flow and the power and versatility index. You found it in the bedside. Usually the HeartMate 3, they have different clinical conditions: hypovolemia, hypertension, heart failure, inflow and outflow, cannula obstruction. This will affect all in the screen, which is the flow and BI, which is the versatility index and the power. And according to the cause, you can treat the patients. What's the difference between HeartMate 2 and HeartMate 3? There is a study with trial comparison between the 2 and 3, and they found less complication in the HeartMate 3 in form of stroke and bleeding. This is the same study. It is 189 in HeartMate 3 and 172 patients HeartMate 2, and it is decreased in the HeartMate 3 the number of stroke and the failure. This is how to fix it, how to fix the device in the apex, and how to connect it to the aorta. And you found it by X-ray in the bedside, the device there. There is in HeartMate 3, there is handling of how to handle the suction infect, which is the collapse of the LV with the interventricular septal deviation of the left side due to negative pressure. This depends on if this patient hypovolemic or bleeding or tamponading, and this will rule out by the echo or and treat according to the cause of the patient. How to manage the patient postoperatively? The management started from the OR. Should be to support the RV. You should start the patient on nitric oxide and Merinone and epinephrine in the OR, and the ventilation usually it will be the same. It is PCO2 is around 5 to 6. They will do TE in OR to see the cannula site and cannula and the septal shift also. In the ICU, should always make sure the connection, and when the patient arrives to the ICU, cardiac ICU, to the drive line, and it is LVAD connected to the controller. You will see the monitor for the BI and also the CVB to monitor the preload for the patient. What are the complications of that? The most important, which
you
is...
have 5 minutes to finish. 5 minutes to finish.
Okay. Ischemia and hemorrhagic stroke. Second one is infection, which is the most important to killing to the patient. Which is the other cause is the anticoagulation in the ICU. When you start anticoagulation, should be platelets more than less than 40 and should be platelets normal and there is no bleeding. If the patient in ECMO before, you should wait for 24 to 48 hours. In the Berlin heart, the target is higher, to 60 to 80 the BTT, whereas in the HeartMate 3 is lower, it is 50 to 65. What are the experience for King Faisal with the device? We start the transplant pediatrics from 2019 to 2020 to prepare the program and prepare the patient and prepare the protocols. And in 2021 we start Berlin Heart, and 2022 we start the HeartMate 3. Before 2021, it was adult team who started the device. They have 12 patients receive HeartMate 2, and 87 patients implant the HeartMate 3, and 3 for them is pediatric. In 2020-2012, the survival rate was 23%, whereas in other era, 2013 to 2022, the survival is 75%. In the pediatric, we have 9 patients now have Berlin Heart, 13 patients HeartMate 3. The survival is 75% in Berlin Heart and 92% in the HeartMate 3. We have 9 patients. The age is 5 to 11 years, and transplanted now 7 patients, and 2 died. In HeartMate 3, we have 13 patients, 9 at home, and 3 transplanted, and 1 died. The challenges and in the future of this patient, now there is era of to put device in failing fontan. Failing fontan, there is issue with the pressure is high, so we have to do cath before to make sure there is blood pressure is low, so you can optimize the device, and to bridge him for transplant. But this one I think need more time. Concluding, the number of children with severe heart failure increasing, whereas the number of organ donation now it is not available, and I mean decreasing in the number, so that the ventricle device is now improving the survival. The appropriate selection of timing of ventricle device now is a key, and also that important for the teamwork to be successful pediatric device. Future for single ventricle to put in device, this one need more study and more time. Thank you.
Thank you very much, Dr. Alwan, for a nice overview of this important topics. Now we are going to move to third sessions in regard to palliative care. And I'd like to introduce and welcome speakers. Dr. Ma'ad Abdel Salam is a pediatric intensivist at King Faisal Specialist Hospital, and he's a Quality Director of Pediatric Critical Care. So, what is a palliative care? It's a really an emotional and spiritual support to the family and the patient, and it usually started from time of diagnosis until the patient die or cured. So this is I'll start with this one, with this statement. The previous U.S. President Carter wishes, and this is what he, after prolonged numbers of hospitalizations, when he get to come to the hospital every now and then, either for medical management of his pneumonias or other underlying disease. And then at the end, him and his family decide that they need to go to probably palliative care. There is no point of just going to the hospitals every day now and then, and just, he will just trying to get whatever intervention could be done at home until he passed away. So I'm having a few questions. I would like to address them, and also I'd like to hear from the audience in regard to this question. So let's start with the first one. Do we need a pediatric palliative care services in Saudi Arabia? Can we have hands up?
For sure. I think we have a lack of services in our hospitals, and I think no one having ownership for those patients. Sometimes it will be lost between the specialists or specializing in the services, and nobody having or supporting those patients, running between the clinics, and no one really take care of those patients until they reach a point that already like terminal and near death. And that time when the services interfere and take care of those patients, saying this, such as mentioned, such of early intervention always support the family in earlier on.
Thank you. Second question, do you have a pediatric palliative care services at your institutions? Can we have hand motions? So probably this is the way we are discussing this. This is where we need to have an awareness, and each of us, when we go back to our institution, we need to think about, shall we do a palliative care services in our institutions? third questions. At which stage of the disease palliative care services should be initiated? Anyone from the audience? Anyone from panelists?
Thank you for this good question. My name is Dr. Am, pediatric neurosurgeon, King Fahd Hospital. I believe in pediatric neurosurgery atmosphere and environment. The stage should be initiated when the outcome becoming limited and the family try to starting to understand this outcome, and the patient will develop complications that cannot be treated.
Thank you. Dr. Khalid?
And I think we should start when the patient start to be, I think when more than 48 hours patient in the ICU, should start from there, and because it is only the palliative care is not only the if patient need to be very complicated or he has any complication, because sometimes they need to have social worker to have to improve the relationship between the parents and the physician, family meetings, and that's my to be started from the start, and not to wait until the patient need to be DNR or he need to be in the last stage when he has more complication and will be later on.
Thank you. This was earlier on at initiation of palliative care. Palliative care only was introduced to patients that probably lost hope, and there is no more intervention could be done. More recently, palliative care should be done at earlier stage of diagnosis. Most of international institutions now, they initiate palliative care upon diagnosis of patients. So if I have a patient who is going to go on, an immune deficiency, is going to bone marrow transplant, the palliative care initiated at that time, because we know those patients, they are going to struggle and suffer. For neurosurgical patient, palliative care services probably need to be done especially with those with recurrence of brain tumor or patients who have been diagnosed brain tumor. And some of them we really know, especially those that we know that their prognosis is going to be poor. We really need to start an earlier phase of palliative care rather than at the end of the disease. Next questions. Does early palliative care prolong survival rate? What's the audience? Panelists? Yes, it does. Okay. Can you just tell us, please?
Dr. Haji Zohir. Yes, early palliative care prolong the survival rate because it will help in the prevention of some complications that might arise and will deliver better health care to that patient.
Very good. Dr. Ayman?
I think broadening the spectrum, broadening the question or the scope of the question is, do we really need the survival or the quality? So, and I think the palliative care concept overall is very important to shift the gear from focusing on the survival to focusing on the quality of the survival. So rather than have him in the ventilator for a long time unconscious with multiple complications, let him have probably less survival but with better quality time with the family, with the surrounding, enjoying his life at that time. So I think, yes, I agree, it is very important to improve the quality of life, and also by improving or anticipating complications, it might improve actually the survival.
Thank you. There was a lot of debate about does palliative care improve survival, and most of people, when you talk to them, can we transition this patient to palliative care, they said no, because you are going to let him die. But differently from the studies we know, and just put this reference for these studies, palliative care patients have been shown that their survival increased by 15% and compared to patients who were not had a palliative care involvement at earlier stage. So those is for the people that saying, if you put him palliative care, he's going to die. No, study shows those who have been in palliative care probably have been better care, probably their symptoms have been improved, and even if they are palliative care services, and the overall, improvement in regard to the patient and the family, support. Moving to second question, when do you think we need to integrate palliative care education training? Audience? Does it at medical schools, internship, residencies, or fellowships? Medical schools.
A comment here.
Sorry? As part of, sorry? Okay. Anyone from the audience?
When we talk about introducing a concept into education, we have to talk about at what level the introduction. Also, sometimes we'd like to have some basics at the medical schools, and some become more advanced in the residency or the postgraduate training, and even more specialized when you talk about the fellowship related to palliative care, for example, the ICU, the hemato-oncology services. So probably there is different level of involvement, but the aim is to start the basics, and then to go from novice level to an expert level with the more related specialities in the postgrad.
Thank you. So earlier on, probably at our levels, we were not taught about palliative care. I think we just know it a bit probably late, and I think this is a times that we really need to introduce it at earlier stage of medical students and internship and residency. There have been studies published about medical students' awareness about the hospice care in Arab and Muslim country, and only 23% of them they know about hospice care. So there is a major lags in knowledge about palliative care services and related issues in our medical community, and I think this is a time when we need to improve this regard. Do you have pediatric palliative critical care in your institutions? Audience or panelists, anyone?
So I think to start with the concept of like palliative care, the issue always from ourselves, from the physician who's linking of the palliative care related to DNR or death. I think many of patients who go through will be like needed of the services. I think King Faisal Hospital started with palliative care services. It started from the oncology services, because always like linking to the oncology and the concept from oncology. And I think they established very well advanced services, and also expanded for the last 2 years. I don't know if you will present Dr. Tariq experience or...
I will. I'm just going to show you some of the things we did at palliative critical care in our institution at King Faisal. As you know, palliative care started in 1992 at King Faisal Specialist Hospitals. And then until now, we do have a 12 center. They are doing a pediatric palliative care in generals. 6 of them were accredited by Saudi councils. We started our pediatric critical care palliative care services in 2019. I'm just going to show you some of, pictures that we have been done over the last couple of years in regard to palliative care. As you know, pediatric critical care is used to be an area that, no one is allowed to visit, keep the patient or the child by himself, patient and family struggling and suffering. We concentrate in regard to medical surgical management, but we never address, how much patient and family struggles. Where do we need to improve their psychosocial well-being? So there have been a lot of flags in regard to management of those patients. So we start to involve our patient even in their critical care. And you do have some time patient in the critical care, they are cognitive, chronically ventilated, they communicate with you. So we get them and get their family to support in trying to improve their well-being and the critical care. So we try to get, يوم السعادة العالمية, happiness days, try to involve them, give them gifts. iBands, we trying to give them something they could, get, some time when they are spending very long time in the ICUs. Trying to make parties for them. So any patient in our units who stay more than a month, chronically ill, but he's cognitively can communicate, we do parties for them. We trying to give them some entertainment in our units, so they enjoy their times. This is a patient who's an oncology patient that he have been in the hospital for 6 months. He had refractory disease, and he was really very sad.
Mic.
I never saw
د.طارق.
him smile. Sorry.
The mic.
I never saw him smile unless we do a party for him, and then we did a party. He smiled. Few days later, he passed away. Rahmatullah alayhi, shafa Allah fi jannah. So we're trying to do our best, trying to entertain our patient. We have a play therapist who comes and playing with patients. We try to mobilize patient. Get them outside of their room, get him down of the units, take him to the supermarkets. We also get our patient to draw. One of our patients, he's a guest. He gets the best photo in the hospital, and he get very good reward from the institutions. This is the one who really gets the best one. I think the hospital gives him, a credit for that one. So we involve families who have been staying with us long. We go to social services, psychosocial support. They sit with the family, trying to help them when they have their crisis. I'm just going to show you.
الله يجزاكم خير. ولا غريبة صراحة من عيالنا وابنائنا. فنيابة عن امها وعني اشكركم بكل ما تعنيه الكلمة. حجم السماء. شكرا لك.
This is one of the party for one of our patient post liver transplant.
يا سلام يا سلام يلا افتحيها ورينا يلا يا سلام
trying to get patient engaged, trying to improve. I'm sure some of you, I don't know, maybe anyone of us been admitted or required an ICU with his family member, and you could see how much. It's like a prison, like a sijin. And it used to be an ICU. No one allowed to go, and no one is visit. Only regular, just visiting time. So this is at the end. So the idea is being that we really need to promote palliative care services in our institutions. We'd like to make sure that we don't only concentrate in medical management and end-of-life decision, but we really move on to improve quality of care of those terminally ill patients. Are there anything from the panels before we conclude?
Thank you very much, Dr. Tariq. I think with the lack of palliative care in our hospital, and I think just to start, because the concept of the palliative care should be like now in 2024 should be like highly appreciated, and we need to fight for our patient. And I think it started with the primary physician, primary pediatrician, having a services, to initiate the services, it will be a challenge. But I think to start with in your institution, and after that we'll find out it's many support, but need to be start the services first. Thank you very much.
Thank you very much. So now we are going to move on discussion. So discussion is going to involve, the previous talks in addition to the panel. So if you have any question, please introduce yourself. Can someone help us in getting the mic, please? تفضل دكتور.
شكرا. I'm Samir Al-Abdi, consultant neonatologist. Thank you for this nice presentation, and I have a question to both Ayman. Regarding disclosure to the family or disclosure of the medical error. In the regulation here in Saudi Arabia regarding the insurance company, if a physician admit to the error, the insurance company will not cover the insurance. This is very clearly stated in their policy. So how can you balance between disclosure to the family and then you lost your insurance coverage if you admit that? Thank you.
If you are talking about the malpractice insurance, this is why it is there. I think the malpractice insurance is for medical errors specifically. It's not for the complications related to the disease, not to the complications related to the care. It is related to the malpractice by itself. However, there is a difference between, as we said, in the medical error, there is two types of human errors. There's intentional and unintentional. So if you're talking about the unintentional, the malpractice should cover it. Probably what you're describing is if there is an intentional lack of compliance with the rules, compliance with the protocols and pathways, probably this might be in this category. However, most of the awareness about the protocols, high quality standards of practice and patient safety practices is among all the hospitals. So I assume that probably most of the medical errors are unintentional, either related to improper action or incomplete action, or because of probably misdiagnosing or thinking problems. And I think nowadays with the significant awareness of the high quality culture and patient safety culture, as well the accreditations happening with the significant improvement in the access to policy, procedures, guidelines, development of hospital and healthcare system in general in the Saudi Arabia, probably the non-compliance should be getting less and less over time. But the most important thing is try to have this system in place.
Thank you. Questions?
Thank you. That was really great, Dr. Ayman. That was even a great answer too. I'd like you, Dr. Ayman, this is Dr. Anwar from Senior Clinical Pharmacist in MCH. One more issue to raise upon our colleague's question. Now, I'd like you just to put on or to categorize carelessness and awareness, or lack of awareness regarding the medication error happens. Do we have to categorize it as a kind of intentional or non-intentional, and where to put just culture concept at this point of view? Thank you.
Thank you very much. I think one of the slides that probably I went quickly over it is the just culture versus the reckless culture. And I think this is two different issues. Sometimes we are overdoing the no blame culture. Overdoing no blame culture, so there is no responsibility, no accountability, and I think this is not in favor of improvement of our healthcare system in general. And the important thing is to have the openness to admit errors and to report them in a timely fashion, and to have a system in hospital in place to anticipate problems. So either the failure mode effect analysis or the prospective analysis of the risk management for every patient, rethinking the process of medications, prescription, medication administration, medication dispensing, going through every step and then thinking about what could go wrong with this process and how we can prevent it before it's happening. This is one aspect. Second aspect is to have in our system an embedded safety net. So check it once, check it twice, involve the technology available, and have multiple areas of checkpoints, multiple levels of checkpoints. Nevertheless, high compliance, high auditing practice is very important. Otherwise, this multiple level of checkpoints will be just a Swiss cheese model. So this is very important. In the medication error, I think awareness of the physicians about what is expected from the medications. For example, one of the common medications we use in the ICU is amigdalicides or the vancomycin, and both have nephrotoxicity in patients. So knowing that probably this is a high-risk medications, knowing that this is a high-risk patients is very important to prevent. Even it could be an adverse event from the medications, but I think the overdose could happen, especially in patients with obese patients, or patients who have improper weight or stayed longer time in the ICU and their weight have changed, either lost weight, so the dose will be significant dose over them.
I could see one of two important things, at least we noticed that sharing medication errors within the hospital staff is really important. Nowadays we do have more of discussion all of this medication error through the huddle, through higher administration distributing it to the staff, in addition to training new residents who's joining the program to really help in reducing medication error within the institution. Are there any
if I may add just to this, one of the important practices that it is one cornerstone of most of the accreditation standards is medications reconciliations, for example. So this is sometimes we think as this is checkpoint. It is not only a checkpoint, but this is very important to know exactly what patient receives and what's the doses and what's continue, what's not to continue. The medication error has also other points regarding the stress, the burnout, the high load of the patients, and the high acuity of the units. I think all of this is, as a system-wise, need to be taken care beyond the human factor.
Are there any
questions?
Yes, yes.
Assalamu alaikum. Raad Sadiq, pediatric intensivist. Thank you, Dr. Tariq, for this really awareness about palliative care. What problems sometimes we face for palliative care is the infection control issues. I remember some occasions, the infection control practitioner, they will have concerns to welcoming some people, to bring some toys. He said this is against the infection control policies and the procedures. So what do you think, how we can solve this sometimes conflicts if we bring, like as you interestingly showed if you bring like toys, like peoples. So this is, I think, one of the factor that we need to manipulate to really increase the awareness of palliative care. Thank you.
Thank you. What we do, طبعا, we always go with infection control measures. Patient in strict isolation or related to that, we don't do that. So we try to choose patient who doesn't have any, patient who does have standard precautions. So we do have a limited access to the patient who had an infections issues. We do have very good collaboration with infection control in regard to how much we are allowed to do so, what sort of precaution we need to do. So I think it shouldn't be a barrier, but it's something that need to be looking for when we get those type of activities. Last questions. Yes.
My question to Dr. Khalid. Regarding your experience in King Faisal Hospital with LVAD and HeartMate 3, was it only with the patient with dilated cardiomyopathy, or was applied also to patient with end-stage complex congenital heart disease? And if it's yes, what was the outcome?
Can you read the question? I can't hear it.
Yeah. My question regarding your experience in King Faisal Hospital with HeartMate 3 and Berlin Heart. Was it only for those patients with dilated cardiomyopathy, or it has been applied also to the patient with complex congenital heart disease in this stage?
It is only the dilated cardiomyopathy, most of them. And the selection of Berlin Heart and HeartMate 3 depends on the patient and depends on the size of the patient. An experience of the surgeon also. All of them, it is my knowledge, it is all cardiomyopathy.
Thank you.
Thank you very much for the audience, and thank you for the speaker and the panelist. It was a great sessions, and looking forward to hear and to learn from subsequent sessions.